Hi, everyone. This is another episode of Unstable Vitals. I'm Dr. Adam Brown. I'm your host with my co-host.
I want to be
What's
the
your
host
name?
and you be the co-host.
Okay, whatever.
I'm Dr. Lara Zibners.
And we are, this is Unstable Vitals and healthcare is unstable. And so is she. So are we.
That's right.
That's right. And we are here today with Dr. Stephen Farmer. So good to have you here in the podcast studio. It's really good to see you. And so, fun fact, let me just go ahead and rip the Band-Aid off. So Steve is my husband. So he puts up with this instability.
I'm sorry. Is he in therapy?
Well,
that's confidential under HIPAA.
It's not, because I'm not your doctor and you're not an insurance company. Wrong. I thought you were supposed to be a government regulator. And do you know the regulations?
Do you know where you are and what your name
Taylor
is?
Green on you about like this. Then that wouldn't last very long because she's not too smart. But anyway, welcome to Unstable Vitals. So good to see you. We have a lot to talk about, Steve.
Well, thank you.
Can we just leave your personal problems at home, though, and focus on healthcare?
Hey, my health is very important.
Okay.
And it really, if you ain't home happy, then your healthcare ain't
Right.
happy.
Happy life, happy wife, happy life.
I
No
don't know.
money, no honey. I mean, it's something like that, right?
I don't have a wife, so none of those things apply to me.
Okay, whatever you say.
All right. So let me frame out the discussion just a little bit. Today we brought you in because you are one of the guys, or were one of the guys, that was making regulatory policy for healthcare in the United States. I mean, you were at Medicare and Medicaid. You recently left. And we thought it would be a really good idea to bring you on here to talk about, some of the rationale and the reasons that policy is made and how do we fix some things that are not right. But before we get into that, is healthcare in the United States unstable?
I do think so. I think it is because a variety of reasons. I'm sure that you've discussed those already, but it's increasingly unaffordable for many people and outcomes are not what they could be.
So before we go into those details, because I think those two things that you said, it's not affordable and the outcomes are bad. You're certainly taking there a patient perspective, right? But
that was very empathic of you. I like that.
I know.
Yeah,
and
it's
it's
because normally the motto is buy cheap, buy twice. But in the US, what you're saying is buy expensive and still not come home with anything.
I don't really know what she's talking about. but sure, absolutely. Yes, Laura.
Did you get it?
Nope, I
Okay,
don't
fine.
get it. So, Steve, despite what
Me.
Laura said, tell us more about your background, because that answer that you just gave was informed, most likely, from a lot of who you are and how you got to where you are. So tell us more about you.
Yeah, my background has taken a path which is pretty unusual. I grew up all over the world, and I've always had an interest in other cultures, living overseas, and so I had that part of my past. But I've also been fascinated by medicine, and I remember in elementary school creating a model dialysis machine and artificial heart.
I did not know that. Oh my gosh, are you serious?
But I knew that I wanted to be a cardiologist, and
Dialysis, friends, is not for the heart, but sort of. It's for the kidneys. But go ahead.
they do connect to each other. Yeah, they are related.
Well, I think the dialysis machine keeps the heart from stopping. When the kidneys stop doing what they need to do to keep your heart from, because I remember a few things from medical school. And that's one of them.
Okay. Thank
Potassium.
you. Yes.
Potassium.
Yes, go.
So I thought I wanted to do international relations and also medicine. And the manifestation of that would be to work in the World Health Organization or an international health body. And as a senior at Stanford, I did work in Zimbabwe on the HIV pandemic. And in that role, while I was there doing my research as an undergraduate thesis, Mugabe, who was leader at the time, started shooting people. And it became very unstable.
Different kind of unstable.
Different
Like
kind of
holy
unstable.
shit, let's get out of here, unstable.
Yeah, and you know, in that experience, I contemplated what type of long-term role that I really wanted to have, and I was fortunate to win a Marshall Scholarship and went to London and did a PhD. But they let me change my focus from international public health to more domestic UK public health and health policy, and I then went on to medical school. Realized that I didn't have the training to understand the economics of healthcare in America because it's so different than it is in the UK. And so I took a leave of absence in the middle of medical school and did management consulting and then venture capital and new venture management before returning to medical school. So I have a breadth of background coming into this, but all of it rolls up into wanting to not just treat the patient in front of me, but treat the population have a much greater impact than I possibly could have just by patients at my practice. But I like to have a blend of both.
And I'm going to point out that in that short little spiel, you let us know that you went to Stanford.
I was going to say name drop.
Right, like name drop. And I got this like fellowship. Do you want to tell us where you went to medical school, dumbass?
Yes, yeah, dumbass. Where'd you go to medical school?
Where'd you go to medical school, dummy?
I went to Yale.
Oh, so stupid.
Such a
Oh, yeah,
dumbass.
right.
Yeah. And
The Yale of Granada.
Yeah. Yes, that's spelled Yell versus Yale. Yes, very, very, very different.
Yes, totally.
And then hold on. Where did you do your internship in internal medicine and then cardiology residency fellowship?
So I did it at Penn.
This again, totally stupid.
Dumbass.
Yeah.
So
fuck you.
Yeah.
All
God.
right.
Okay.
Okay.
Public
On to
school
other
kid.
things.
Okay. Anyway, so recapping, international man of mystery. My brother used to call him like MI6 because he really thought that he was probably this guy that was trying to like infiltrate into the U.S. And he would say like, "Oh, I've lived in Bahrain and I've lived in London and I've lived in Switzerland and I've lived in California," and somehow Houston got thrown in there. That's where he lost the accent. Actually,
Yeah.
did you know that?
In Houston?
It was Houston.
At gunpoint?
Probably. I mean, if I were 10 years old and I was in elementary school and I talked like a Brit, and then all of a sudden
and then all the kids were yelling "pansy, pansy, pants on fire."
Right.
I would also start to talk like this.
I talk,
I talk like that.
White Lotus, you know. So I'd say bright white lightning real fast instead of the way they say it around here.
And so it happened.
And so it happened. Okay, so you had this really amazing kind of educational career where you're saying, I want to do international relations. You were in Zimbabwe. You did HIV research, wanted to work for the World Health Organization. You started medical school, did your PhD here in London at London School of
Hygiene and Tropical
Medicine.
Mm-hmm.
Yes, of course,
another
just
stupid place for dumb people.
You know,
That's
right? And then from there, you finished out medical school. Then you went to Penn. You did internal medicine and cardiology. So you are what we call a mud fud.
And that's where you guys...
An MD PhD. That is where we met in 2007.
Because you're also a total dumbass.
I'm a dumbass too,
Yeah.
but you know it's but we already knew that.
Well, yeah.
Yeah. So anyway, so we met, best decision of my life, 18 and a half years ago. So I know, right? So we met, and I remember, one of the things I remember is that you always wanted to do something bigger, high impact, where you were impacting lots and lots and lots of people. Yes, you practiced, but you went to Northwestern. At Northwestern, you were on faculty there. And that's really when you started kind of leaning into this notion of how do I impact people in a broad way. So tell us a little bit more about your NIH work and then from there.
Yeah. So in my background and my PhD, what I really wanted to understand is what are the policy levers that can affect healthcare outcomes on a broad scale. And there are different levers that you can pull as a federal regulator. Those can be pricing policy, or you can have rules around how different things can be accomplished, or you can have medical malpractice policy. So, for example, the situation is very different in Texas than it is in California. In Texas, you essentially have to prove gross negligence, and you practically have to
intent.
say, "I am going to hurt you now."
Yeah.
Right?
Do I have your consent? And if not,
if
yes.
Yeah,
not.
you don't need no that detracts from the whole impact of
Right.
I'm going to hurt you now, you know.
Right.
And then California, it's at the other end of the spectrum and much more
Litigious.
litigious.
Right.
Yes, right.
Yeah, and so like from there, that started kind of the beginning of, okay, policy decisions on the federal and state level have broad implications on the individual's healthcare and on the
Yep.
state's healthcare. So, I think one of the reasons why we wanted to have the conversation with you is that you said right at the beginning why or that healthcare in the United States is unstable. And one of the reasons is because it's too expensive. People can't afford it.
Mm-hmm.
That was one of the reasons. So you kind of, let's fast forward through your time going from an NIH R1 researcher all the way through to in 2016, you got hired to be at CMMI, the Center for Medicare and Medicaid Innovation. Burning question, is it innovative?
Well, what the Innovation Center tries to do is to change the way that people are paid for delivering healthcare. In America, historically, we've paid on a fee-for-service basis, which means you do a service, you get paid. The more you do, the more you get paid, which encourages people to do as much as they possibly can
This is
to
the cafeteria model.
optimize your revenue. And what you pay for is very carefully defined across a suite of services. You get paid for patient encounters, you get paid for doing procedures, but you don't necessarily get paid for coordination or talking to the patient for enough time so that they really understand what it is that you're trying to do for them. And the consequence is that you really don't optimize the care that you're getting, and it's very, very expensive. So what the Innovation Center tries to do is to reframe the way that you're paid, to pay in novel ways that make you perform better financially as a practice when your patients do better and when you're more efficient. And examples of how that can happen are if you are paid on a fixed fee basis for care of a primary care patient, you can then say, I'm going to hire a social worker to help a patient navigate the healthcare system to prevent that readmission that is massively costly.
Right.
Every time that patient gets admitted to the hospital, it's $20,000. You can imagine you can use a lot of social worker time to figure out what the antecedents are to that hospitalization to try to prevent them in the first place. And that's much more forward-thinking, proactive, population health based. The other thing that it does when you pay practices differently is you think very differently about your patient population.
Less transactional.
In traditional fee-for-service, the patient comes to you, you see the patient. There's less of, it's the patients that don't come to you that are the problem,
Right.
the biggest problem. It's the patient with a diabetes, uncontrolled hypertension, who skipped their last 3 visits with you and hasn't been seen in a year and isn't on any medications, who is most likely to have a catastrophic outcome in the hospital, right? So when you're paid for managing a population and you are closely monitoring what the outcomes are in that population, your easiest intervention is to say, these patients are not being seen, they need to be seen, and I'm going to call them in and reach out to them. And I may need to reach out to them using someone that sounds and looks like them to deliver a compelling message that's engaging and brings them in. So the Innovation Center tries a whole series of new ways of engaging with practices that allows them the greater flexibility to deploy different types of resources to more effectively manage patients.
So as you were talking, I had a really terrible thought, but I'm wondering if it's a thought that, and I have lots of those, but this is relevant. I'm wondering if it's a thought that maybe some people have, and it explains some of this approach, which is when you said they might have a really catastrophic event, my first thought was not catastrophic enough, because then they wouldn't cost the system anything. right?
Yeah.
And do you think that maybe, you may not be able to answer that, but is that part of the thinking maybe behind some of these, we'll just let them, and then they won't be a drain on the system at all?
There are some very, very serious ethical issues around that whole issue, but yeah, sometimes the cheapest thing is not to treat it, to let a disease run its course. But I think as a society, we've decided that we're going to try to optimize people's health and quality of life to the extent that we're able, and that's everyone's expectation generally.
So the CMMI, the Center for Medicare and Medicaid Innovation, it sounds like to me it's a bit of a misnomer, at least the way that the society thinks of the word innovation. It from the perspective of payment of
It's
healthcare,
payment innovation.
it was very innovative because it
Yeah.
was shifting from fee for service to, we hear the term value-based care or bundled care payments. We can talk a little bit more about that to kind of get a look under the hood there. But it was more about that, not about creating like widgets or things, AI for healthcare or things like that. That wasn't necessarily the premise behind this new entity, CMMI, that came out from the Affordable Care Act, correct?
Actually, the bundle payments or some of these different models can leverage AI. If you
Right.
can use AI to get to that better outcome more efficiently, that's how you succeed within these models. So that's an important strategy. So the payment model, the way in which you're reimbursing people, drives behavior.
That's more of the outcome.
Right? It drives behavior and investments and strategies that practice engages in to try to improve health, which can include innovations like AI, or just basic things like making sure that the patients understand the medications that they're supposed to take and how to take them.
So can I just put a finer point on that? So for example, the innovation is first saying, and this goes back to our financial incentive conversation. If we change the financial incentive, moving away from a cafeteria or a restaurant style, we're going to just kind of pay for everything that you order on the menu, versus ensuring that every person who walks out of the restaurant had a really good experience and that it wasn't too expensive and had a good meal that didn't cause them to have salmonella poisoning, then there's going to be innovation occurring. That's not just the payment innovation. There's going to be innovation occurring of like, how can we make this food better? How can we make this food more healthy? How can we make the experience better? How can we make, easier to order without having to wait for someone coming from the back? Like that's where it's a yes and. It's a yes, it's an innovation for payment. And it's also, that flip in the financial incentives is going to push people to figure out how to do things more efficiently, and that may be leveraging technology. Is that right?
Yeah, that's right, but it's even beyond that. That's how you start to think about these different levers, right? So if you change the practice, you might change the medical malpractice liability piece of it, or you might violate the anti-competitive Stark laws, so that you can't own the facility or have a financial relationship with the facility, which makes it very difficult to collaborate to achieve that better outcome. Within the payment models, we can sometimes relax some of those rules and hold harmless from some of those broader regulatory frameworks which try to prevent kickbacks and really negative financial influences on practice.
What are you going to say? Go ahead.
Nothing. You go ahead.
So
I'm just like stunned by the brains that are in the room, right? Like I think I
it's
get
his,
it.
It's his.
I know.
Yeah. I mean, the thing that kind of I've always struggled with this idea is that it's great. We've got CMMI, there's an innovation center, these ideas, these theories around how it can work and come out, but there are major barriers to actually seeing some of these different types of value-based care initiatives come to fruition. So, and actually make its way down to not only changing the financial incentive, being meaningful and not being overly burdensome. So, we're calling this episode kind of Regulation Nation, when in fact, because
God, you stay up at night thinking these
I
things,
know.
don't you?
But Steve, like, what are your thoughts at some of the barriers of actually seeing the full kind of transition to the shift in incentives with these new payment innovations?
I think the biggest barrier is the complexity.
Okay.
You know, when you think about all of the factors that I just raised, malpractice liability, navigating all of the existing laws in fee for service, changing your case mix of your staffing mix, right? Completely thinking differently about your patients, not just seeing the patient in front of you, but the patient who isn't in front of you. Uh, Doing all of those things and modeling that financially as a solo practice or a small practice is often beyond the scope. And when you have to think about, you need sophisticated software packages to also navigate that and connect and track your performance, that can also be beyond the scope of what you're capable of as a small practice or even a small system. So that's one impediment to effective implementation of value-based payment. Another is lack of clear communication and engagement of the physicians that you're trying to influence. I harped on this endlessly when I was at CMMI, and unfortunately, it was not a message that resonated with the leadership. But if your intent is to try to get physicians to think differently and practice differently, you need to communicate with those physicians directly.
Yes.
You have to create a compelling why and what's in it for them. And if you don't accomplish those things, you're really unlikely to get widespread change. Medicine is inherently conservative. You practice the way you trained. You deviate very slowly from that because you want to make sure that what you're doing is the right thing to do.
Right.
And
the move fast and break things is not a great thing.
That's not for medicine.
Not for medicine.
Right.
Well, and I think what you're explaining is now I have in my head this whole like puzzle on the wall where if I pull one lever, I don't necessarily know the knock-on effect it's going to have on all the other things. And that's part of what we talked about when I showed up to business school, and it turned out I didn't know anything about anything. But just the complexities and the it's a spider web. And if you pull one string, you just don't know what other string you unravel.
Which is why the Innovation Center is designed, every single model is designed as a test. Every single model, every single year goes through a very detailed evaluation, both to establish whether or not quality improved and whether costs changed. Now, one factor that we didn't talk about yet is gaming. And gaming is a concept in economic theory that people respond to the game that they're playing. If you're in fee-for-service, your game is optimized volume.
That's right.
Right?
This is the financial incentives we talk about. It's game.
Financial incentives.
Yes.
Within capitated models where you're paid a fixed fee, no matter what you do, you're trying to influence the capitated rate. And you can do that
or reduce the spend.
Right.
That's right.
By reducing the spend or optimizing the payment. And when you can do those things by changing the way that you code patients. And if you more aggressively capture the comorbidities that a patient has, it appears that patient is sicker, and therefore your case mix adjustment or how much you're paid goes up. And we see within these models, many of them, there is a year-on-year, everybody appears to be getting sicker. And what's really interesting is there was an economic study or a health services research study where they showed that people that moved from an area of low testing to high testing, their apparent case mix changed pretty substantially. And it's just local coding behavior.
That's interesting because when I was in my first attending job, we were told no matter what the patient's there for, make sure you get a full review of systems and a full past medical history. It doesn't matter if they're there for a splinter in their finger because we wanted to try to capture, right? Taking a splinter out of a finger of somebody with diabetes and some underlying congenital issue is much different than, it's not really different than, but we were just told like you just they just said your job is to mark up that chart as much as possible so the billing department can capture as much as possible. And who am I to question it? Once again, we go back to this conversation. I'm just doing what I'm told. I don't really understand. And who am I to be the one person in the department to say, oh no, I think I'm just going to mark splinter, right? I'll get fired.
Right. Or you get your name on a board and you get talked to by...
I don't like to be yelled at. I really don't.
Then imagine like as more and more people upcode, If other people don't, then their reimbursement is going down because you have a fixed budget, so all of the payment rates go down, and you end up with people that are not focused on the coding do worse than the people that are focused on the coding, and it creates an inequitable system.
That's right.
So yeah, it is incredibly complicated.
Who knew?
I'm of the belief that
I didn't know
the
that.
more simple that you can make it, the better.
That's right.
So you had worked on, and then we'll switch over to your latest role at CMS. You had worked on the bundled payments program, the advanced BPCI advanced. Tell us what those letters mean, and then kind of what you did with that.
Bundled payments for care improvement advanced is an attempt.
Say that real fast.
Bundled
Peter
payments
Piper.
for care improvement advanced.
Peter Piper.
How much wood could a woodchuck chuck if a woodchuck could chuck wood?
Very good. Okay. She's a
You
good
know,
woodchucker.
in the government, we love acronyms.
I know.
Love them.
I know,
Love
I know.
them.
Yes.
Yes.
So bundled payment care improvement.
Bundled payments for care improvement advanced. It's an
Okay.
iteration of an earlier model that was tested and it didn't achieve the intended outcomes.
Mhm.
And the belief was that there was gaming of the coding, and that was part of it. And so we reframed the method of how we approach that model. The model in essence is when you do a procedure, you're warrantying that procedure for 90 days. You are responsible not just for what happens in the hospital, but what happens in the next 90 days, which means that if you send a patient out of the hospital and you haven't coordinated with their outpatient providers and you send them to a excruciatingly expensive facility that keeps them way longer than they need to be there, your economic outcomes are going to be really bad and you're going to owe money. Right. Conversely, if you're efficient and you get good outcomes and you prevent readmissions, and you don't have to do re-ops, and you don't get infections, post-op infections, and those kinds of things, then you perform better in the model. So there were a series of surgical and medical admissions that were included in the model, and we set a benchmark of what it should cost to manage that patient. If you come in under that benchmark, then you could potentially participate in the savings. If you come over it, you may owe money back. And all of that is adjusted for the quality of the service. What we learned from managed care in decades past is that if you don't pay attention to the quality piece, people just minimize care delivery
Exactly.
to perform well within capitation and don't care as much about the quality, and that's not good.
There's that kind of triangle of cost, quality, and access, and that you start, moving on one, the other ones kind of have to
shift,
go. It's
right.
kind of like that squeezing the balloon. So
Yeah.
so that and I think now putting these pieces together, so you worked on, let's work on these payment innovations, and then it was to shift the financial incentive. That then made it incumbent upon people who participated to do whatever innovative activities, whether that was technology or that was hand holding with patients using lower cost services, that created the environment that made that important to do so people could save money.
Yeah.
But then you said, okay, that is great. I've accomplished the goal of putting BPCI Advance into the market. And then you made a shift because you're like, okay, let's just back up. How many people is Medicare responsible for?
It's 66 million people directly, but there are much broader impacts than that.
How many people live in the United Kingdom?
About that many.
Yeah. So like you were responsible for 66 million people. Those are people over the age of 65. So Medicare is for people over the age of 65.
And end-stage renal disease.
And end-stage renal disease. Interesting
Yeah,
carve out.
and disability.
That is a carve out.
That-
And
I think that
disability.
had to do with the origin of it. That
That's right.
it was a government person who had a direct, either he had kidney disease or someone in his family, right? That there was a bit of pork.
Sure. I don't know that answer, but it sounds
Yeah, no.
right.
That's what I learned
Yeah,
at some
that's
point.
right.
I mean, and if you don't know any different, I say we go with the rumor
Go
and just
with it.
spread it.
We'll go with
Just
it. Boop.
spread it
Okay.
wide.
What do
Okay.
you say? We'll go with it. Okay, sure. I mean, you've got 3 doctors here, and if we said it, peer reviewed, yes.
It shall be.
It shall
Oh,
be.
it's peer reviewed now?
That's right, we
I'm
just
reviewing
peered.
you, and I'm reviewing you,
Okay.
and so now it's
Awesome.
This is
definitely
the
sure.
politics of academia. We say so.
Yeah, we say
Yeah.
so. Mhm.
We smart.
So you moved out of that and you said, okay, now I want to do something even bigger. And I not only want to set payment policy, I want to help innovators out there figure out more, and I want to make sure I say this right, of how to navigate Medicare so that Medicare could safely determine what they ended up paying for. Meaning that, just because a new widget or just because a new technology or device is created doesn't necessarily mean that Medicare is going to say, yep, that works. We're going to pay for that for our beneficiaries. Beneficiaries being those people over 65 and people with renal disease and disabilities. You said we've got to do this a different way, correct? Tell us more about that.
Yeah. So when you think going back to bundle payments, if you establish a bundle payment for a procedure that does not work, you can be super efficient at delivering that unhelpful intervention, and you can avoid readmissions, you can avoid complications from the procedure that doesn't work, and you can do it at lower cost than the benchmark, but that does not deliver on value, right? Fundamentally, for anything to deliver value, it has to work. And what I shifted to was the scientific review of technologies to ensure that there is good evidence that they work in the intended recipients in the Medicare beneficiary population, and if the evidence is promising but not yet sufficient, that there is a scientifically rigorous evidence generation strategy in the post-market, so that when they're in the market, we're continuing to track those procedures to ensure that that they're delivering on the promise. And if they don't, they may either have narrowed coverage or lose coverage. And if they do, you may have an expansion of coverage.
So, but does that sound redundant to what the FDA does?
It's not redundant. It's quite different. The FDA is responsible under the law for establishing that items and services are safe and effective, or medical products are safe and effective in the general population. And the general population is quite different than the Medicare beneficiary population. In particular, when you run a clinical trial to prove that a device works or a product works, you're going to pick a population that is the optimal recipient of that intervention, because you want to show your best case. Under ideal circumstances, what could this do? But very often, you're excluding women, you're excluding older patients, you're excluding racial and ethnic minority patients, you're excluding patients with multiple comorbidities. The average Medicare beneficiary is over 65. They have an average of 3 major comorbidities. And that's very, very different than the population that you're studying in most pre-market studies.
Right.
The other major difference, and this is a huge one, is most RCTs, randomized controlled trials, are conducted in academic medical centers where they do clinical trials.
So they're experts in this.
Yeah, that's very different than a community health setting.
That's right.
Oh, yes. I mean, medicine, that was one thing I'm sure you and I learned in our practice, is that a community hospital is very different than an academic hospital in the way that medicine is done. And the patients are different and the resources are different. The access is different.
Also very different to be in a trial and have nurses calling you every day saying, versus you're on your own and you're managing your own medications and your own healthcare.
Yes,
right.
exactly.
So this is real world evidence versus controlled environments, essentially.
And, to that point, you are an expert in real world evidence, real world data. That is the space. And what I think is interesting about the work that you did at CMS, which we didn't say, you were the former chief strategy officer for coverage determination at CMS. The idea was to protect patients, right? Because you want to make sure that whatever device is going out there, even though the FDA said, okay, this looks safe, it was safe for a general population under ideal circumstances. It may not be safe necessarily for, the Medicare population. But it's also good for taxpayers. Let's not forget, my tax dollars, your tax dollars, when we are paying into it, that is going into Medicare. Medicare is then doling that money out to, hospitals and doctors, but also to technology people that are creating things. And we want to make sure that there's good taxpayer value. And listen, as a doctor, I don't want to be putting shit in patients that is not good.
Yeah.
I mean, like, I
Yeah.
don't.
No.
Yeah. And
I
how
mean,
would you
Even
know?
if you're in Texas.
Correct. Correct. Like my brain didn't go away. Even though I had a Texas license for a while.
Did you?
I'm not
Did you
practiced
ask the
on it.
patients before you harmed them?
No, I didn't work down there because of other reasons.
Oh,
but like,
okay,
yeah,
fine.
I mean, I don't work
Yeah.
in Texas.
Okay,
but,
fine. No.
Yeah,
okay,
yeah.
fine.
But so that kind of that policy that you put together, that regulation, that went through the administration, the Biden administration, it is now on the books, correct? And it's one that that is informing how device manufacturers, et cetera, are contemplating their strategies, correct, on new devices, and et cetera.
Yeah, so in order to implement that, what the market was asking us to do is really substantially increase the volume of technologies that we review as CMS. CMS has very few people in the group that actually conduct these reviews. And, by contrast, the FDA is paid on a fee for application basis. So they have much deeper resources
So
to
the more people that
assign.
apply, the more people they can bring in,
Yeah.
the more, whereas you have a fixed.
Yeah, if you
So you're
apply,
value-based, no
right?
fee.
Well, we are truly independent.
Mm.
We are truly independent, and we our primary considerations are our beneficiaries. That is a core of our mission, is to ensure that they receive good care, and also the trust fund, to ensure that patients will continue to receive good care because there's still funds to pay for Medicare beneficiaries. But what we're talking about here in trying to review more entailed substantially increasing the volume with the same number of people, right? So we substantially increased our reviews through streamlining, templating, standardization, through all of the very carefully negotiated processes in an incredibly complicated system, to achieve a more than 100% increase in our productivity as a group. And that was one piece of it. As we increased our volume of reviews, the worst policy is no policy, right? So the more technologies that we can create policies for, the better. The second thing is we created an evidence framework that relied more on real-world data. We allowed for fit-for-purpose studies, which means that the study has to be appropriate to the question. It's pretty simple. It is the study design, the analytic plan, and the data sources have to be appropriate to the kinds of questions that you're asking. And if your question is, does my device fail? You can just track patients that got the device and see if it failed, right?
Well or not.
Right.
If you want to show that you're better off for having received the device, you have to have a comparator, and then you have to use modern causal inference methods in real-world evidence to accomplish that.
This is, yeah.
These are big words. These are big words.
Tricky stuff.
Okay.
Yeah. Okay. So, but it's what's impressive to me is that there is a this is not the side sometimes of CMS that we hear. As doctors, we hear like, oh, CMS, scary people, J-code. They're not the same, actually.
Right.
We hear
They pay
these
nothing. It's pennies on the
pennies
dollar.
on the dollar and blah,
That's
blah, blah.
right. My mom couldn't get whatever, right? We just hear nightmares.
Yeah, but
Yeah.
it's really there are a lot of functions there about you said something that just I've not heard you say before, but I think is really important, is like the worst policy is no policy. And kind of having that chaos really opens the door for really bad things to happen and people to be harmed.
That's right.
So Steve, we only got a couple minutes left. I want to ask you a couple of like more rapid fire type of questions. I'm not going to put you in a bind, but one is, we talked about value-based care. We talked about the more recent regulation. I want to go back to value-based care. What do you think is the future of it?
I think firstly, the macro legislation, I can't remember what that stands for at the moment.
Medicare Authorization Continuing Resolution, something, I don't know, Act.
Nice.
I think it is close to that.
So the
but it's not
macro
far.
legislation expresses a durable commitment on the federal government to value-based care. It replaced the flawed sustained growth
Formula
formula
that
that was
for a few years.
every time costs went up, you decreased the amount you paid per unit of activity.
So doctors got
that
paid less and less and less.
Right,
you got
right.
paid less and less and less
It
every
still
year.
happens.
Right. So in order to get rid of that system, they replaced it with value-based payment as the fundamental core animating feature of Medicare payment. So it is enshrined in the law, and it is going to it's going to stay.
So it's not going anywhere. It's
Yeah.
just we're having to iterate, we're having to improve, we're having to make some
Yeah.
changes, and other payers are adjusting.
Yeah.
Okay, next question is, what is the future of evidence development and the future of technology companies and pharmaceutical companies having to leverage data and evidence to make sure their products and services work?
I think many countries around the world are focusing on RWD, or real world data and real world evidence, to really assess not the promise of therapeutics, but the what they
Actual
are actually
outcomes.
doing, right? In people like you, as a patient, what you want to know is not what is the perfect patient outcome going to look like, but what is my outcome going to look like? And real world data gives you that option because you can study many, 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 many more patients, often in a far greater diversity of settings and for much longer at a fraction of the cost.
Real world.
But not the MTV.
No, not MTV Real World.
No.
That's
kind
not
of
the
like
same.
this
That's
real
not the
world.
same.
Actually, one of our Congress people who's now like head of transportation was on.
Really?
Yeah,
My parents didn't let us have MTV. We didn't
was
have
on
cable
MTV
television.
Real World.
So
Yeah, the new
Yeah, we were old
transportation
school.
secretary was on MTV, I think, Real World. But
Okay.
fascinating. So takeaways. I'm going to give you mine, and then I'm going to
Okay.
give you.
Okay.
Okay. So one is, there's a lot to take away, but there is something that you said that will just be burned into my mind. Is not worrying about the patient that's sitting in front of you. It's the ones that are not sitting in
That's
front
right.
of you. It's the ones that are out there that you're not seeing, is the ones that I should be thinking about, that we as a society should be worried about, is the ones that from policymakers should be thinking about. Because those are the ones that have the brewing issues that you could be intervening on early,
Yeah.
or the ones that may be way too late down the path and now you're having to intervene at one of the most dire moments. So that is one of my takeaways. What's yours?
Mine is that these policies are so complicated that if you pull on one string, you have to have some patience, because what we're seeing is there's real people who want to do the right thing behind them. Sometimes the implementation isn't perfect because of how complicated it is, but it's nobody trying to actively, most people are good and have some patience as we work out the best way to do this. And you can see that he's a good patient man because he puts up with you.
Totally true.
Right?
True.
I mean,
Very
what a
true.
saint.
I know. I don't know how he does it, really.
I mean, you really pulled.
I know. I feel like I made sure that I pulled from the bottom of the barrel when I found my life
No.
partner.
Pulled is a UK term for like you scored a Betty, but he's not a Betty. He's a Stevie.
I don't know what any of that shit means.
That's okay. You went way. You hit way out of your league. You were punching above your belt.
Okay, sure. See, I don't understand all of these. Like, I hear all these terms from UK people, and I'm like, I don't know what they are. Like, the other day, someone said tripping balls, and I'm like, what the fuck is tripping balls? Like, I have no idea what that means. Do you know what that means?
No.
You know what it means?
I do now.
I know. It's like, that was a new term.
It was used in the context of, that's so crazy, like you're high.
I'm tripping.
You're tripping balls.
Okay. Yeah. I mean, I'm going to
All
use
right.
it. Okay.
Well.
But anyway, so Steve, what's your takeaway other than we're crazy?
Well, I think, as you mentioned, two takeaways. One is policy is very complicated and you pull on one string and other things can happen that are
That's good.
I already
unexpected.
said that.
Here,
Yeah.
here.
Way
But
to go.
used
that means that you have to iterate on it, and it's
That's
a
right.
constant project, and it's, you don't put out a final project or product and it's fixed and set for decades. It is something that you have to iterate on constantly and get feedback on. The second is, I would love for our country to get more focused on preserving the good health that you're born with instead of trying to correct illness when you
Yes.
have it.
Yes. Yep.
So, Steve, where can people find you? Can they find you on LinkedIn?
They can find me at ABIG Health.
Okay, that's right, because we announced last week that you are joining ABIG Health. That wasn't actually a shameless plug. It was really, they can find you on LinkedIn, where you put a lot of your information out there, your thought leadership around real world evidence, real world data, how to navigate the complexity of the market, some of the challenges that are happening in the U.S. market right now. So even though you are my husband, I will say this: thank you for your service. 8.5 years with the U.S. government, working tirelessly, and I've seen it. A lot of people haven't, but tirelessly on behalf of the American public. So thank you.
And I'll
thank
say
you.
thank you, even though I'm not your husband or your wife.
He is the husband, gay husband.
But he's like my gubbin-in-law, right? My gay husband.
Gubbin-in-law. Exactly.
Whatever that means.
Okay.
So that wraps up our time.
That
Thank
does.
you
Thank
so
you,
much. I'm
Steve.
your co-host.
And I'm your host,
Yes,
Lara.
Dr.
And
Adam.
healthcare is unstable.
And so is she. So are we.
Wherever you find your podcast.
Yes, you can
you'll
find us on
there.
Unstable. I just screwed that. You can find us on unstableVitals.com or anywhere you want to
get
find
your
your podcast.
podcast.
Yes, and so thank you so much. And we've got some really great guests to talk about these really deep issues. We try to make it fun. We try to make it simple, even though sometimes things are not simple. I mean, who knew healthcare was
This
complicated?
whole conversation was well above my head.
Stand up. That's all you have to do. All right. Until next time, thank you so much. Take care.
Thanks for tuning in to Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit unstablevitals.com to stay in the loop. And don't forget, real change starts with real talk. See you next time.